presenter today, Mr. John Zimmerman. John, it's all yours.
Hey, thanks, Samantha, and big thank you to Weedy for putting on this webinar and for asking me to speak. You know, folks, a couple of weeks ago, they asked, can you talk about innovation in healthcare? So I thought I'd try to do something that was oriented towards some of the consequences that we are seeing from some of the environmental changes, but also recognizing about how we can work together to help us all meet the charter that Weedy is aligned to do, which is to continually help reduce administrative burden. With that said, I'd like to welcome you all to the last week of the first month of the third decade of the 21st century. But ask you, with all that backdrop, ask yourself the following: if it is in the 21st century, why is it still the case that 75% of medical communications are on faxes, a technology and an innovation that was brought to the world in 1842? So something is clearly, we need to do something different. So here's the agenda that I have for today. First, how did we get here? Second, why is this topic so important to us now? Third, well, there's innovation everywhere around the globe, throughout all industries. How does that apply to us? Then a quick review of our environment, and then a focus on what makes a difference. What are those problems to be solved? And then I'll spend quite a bit of time on hope through points of light, and then end up with how are we going to go check our vision, each and every one of us, as we go forward. So let's talk about how we got here. One of the big premises that you'll see from me today is that much of the innovation in our environment now is based on the shifting tectonic plates of how value-based care is continuing to affect the industry. And when you think about it, it's actually 23 years old and counting. Some of us think, I'm one of them, used to think of it as a pretty recent phenomenon. But in actuality, it really started when President Clinton enacted the Medicare Plus Choice into law, and then followed by President George Bush with the beginnings of Medicare Advantage. And this next slide, this slide on the right, is a pretty recent one from CMS about the direction to empower patients and doctors to make decisions, to be delivering supportive innovations and approaches to improve quality, accessibility, and affordability, to usher in a new era of state flexibility and local leadership, and just overall improve the CMS experience. From my perspective, I think they're right on, and you're going to see how that fits with today. So why value-based care, and why right now? As I said a minute ago, it feels like there's two major tectonic shifts going on. One, fee-for-service has not completely gone away. It's still the majority of how most of care is still paid for today. However, value-based care in all its various payment models is also coming on strong. So all of us in this industry have to live right on that fault line. And the tectonic plates are moving, I would argue, faster than ever. So why are we even doing this? Well, first of all, it's affordability with quality, which is clearly the right thing to do. But as you'll see, it's a hard thing to do to improve the patient experience, to focus on population health, to do all this while both reducing costs and making sure that we avoid, as much as we can, physician burnout. The law of unintended consequences with what's going on in our environment today is the fact that administrative burden is going up, not down. And more than ever before, we need that innovation, but we need collaboration as well. So let's look at some of the kinds of innovation that we're seeing around the world, not just in healthcare. I don't know about you, but I read new articles every week, almost every day, on artificial intelligence is here, which then is a cousin to machine learning. Network bandwidth is pretty much zero, right? It's very, very inexpensive. Nobody gets a long distance bill anymore. There's a lot of mobile medical devices, that's MMD, in the world that are doing a lot of good for a lot of people. We also see robotic process automation, letting machines do the work, the routine work that people do. We're now starting to see gamification come into our world as well, into the world of healthcare IT. We've seen a great step forward, I think, with Amazon offering speech recognition as part of what they're trying to do to improve our full ecosystem. And, we do know that ONC 2020 happened this week, and the 21st Century Cures Act is really driving more and more and taking interoperability, like Wheatie started way back when, and taking it to a new level. So this innovation is really everywhere, but there's a few challenges still with that. One of them is, if you look on the left here, as we all know, we have a very, very fragmented ecosystem in healthcare. We have all kinds of different payers and providers and combinations of payers and providers now, and they're buying each other up and combining in many different ways. And each of them has many information systems as well, in various states of maturity. Some of them are 40 and 50 plus years old. Some of them are 40 or 50 days old. So we have a lot of systems that we're working with, and it's very dynamic. The dynamics are not just about the systems and the fragmentation itself. It's new business models. It's new people collaborating in new ways. It's new entrants into the healthcare ecosystem. It's new vendors. There's a lot of dynamics going on. So there's a insignificant challenge to say, well, with all this going on, what should our direction be? With all these drivers, and they're all happening at once, what should I do, and what innovations should I look at in order to make progress in my unique environment? And we're all facing those challenges. So when we step back and look at it, there's really, I would say, 4 major drivers that we need to keep in mind as we make our choices to apply innovations together. We all know that the cost of healthcare is at an unsustainable rate, and we hear the term of bending the cost curve. I'm going to show you some examples of that later. But as we've learned in decades past, it is not a good idea to just attack costs without making darn sure that quality does not go down. In fact, if we do this right, costs can go down and quality can go up in a measurable way. I know we've also seen that CMS and other health plans have been pretty wise about putting the right kind of incentives in place to help address the costs, manage the quality, but do it in a way that provides new and greater rewards for the people who are actually taking the risk and delivering the care. But we have to do this in a transparent and well-managed way, so there's lots of compliance things that come with this. So it's sort of trust but verify. So there's a lot of rules, requirements, laws, policies, regulations, standards, and delivering proof. So I'm going to walk through some examples and points of light where you'll see these things coming to life today. But one very important caution is we have to make sure that we don't increase burnout anymore. It's an issue that a lot of people talk about, and I would argue it's because the administrative burden has rapidly increased as the quest for value-based care accelerates. Something we always should be keeping in mind as we go forward together as an industry of collaborators. So let's take a look at some of the points of light that are out in the world. Let's talk about real innovators who are tackling some of these tough challenges but delivering results along the way. Look, I think it's also important for us to look at, and this is just a small sample of some of the leading organizations who are today making a difference, right? Of course, there's ONC and at healthit.gov. There's a number of other great parties in here, some of the what they call big tech now of Google, Amazon, and of course the people who are doing great innovations at Microsoft. There's industries. There's Weedy, of course, HL7 working together with DaVinci that you see there. I'll sort of wrap up with some really insightful work that CAQH just published last week. And then there's the universities involved as well, and our good friends at EHI, who really are great conveners of, okay, so what are the right steps to make going forward? So let's take a look at some of these in just 1 minute. But one pattern that I discovered when doing the research to try to bring this talk to life for all of us is I started to see that there's an equation where actually 1 is less than 0. So I asked a few of my friends, I said, okay guys, when do you think 1 is less than 0? And in this context, 1 is less than 0 when you're doing some innovation in some fashion, but that's all you're doing is one thing. If it is not combined with the infrastructure or additional innovations from other parties, it's not actually getting adopted. So you spend a lot of time and money and effort and sweat equity to actually realize nothing. So that's when you've spent more than you get, is when 1 is less than 0. So you'll see throughout the rest of this presentation, everything that I'll be presenting is actually a combination of multiple things and multiple parties. So let's get into it. Let me give you this one example. The challenge here is, how do we get those gaps in care that we know are supposed to be addressed into the clinician's workflow, even though the data is coming from a very different source? So in the Southwest, there's an innovative health system that is actually closing those gaps and lowering costs by taking their existing population health management analytics platform, and they're working with some new forms of interoperability to actually surface those gaps into the workflow of the practice so the practice can actually close them. What's I think so important about this is that it is in the workflow of the practice. It is not saying I have to shove it in the doctor's face whenever I think it's right. It actually goes through the MAs, and eventually the system gets prepared for the doctors to act in a way that is consistent with the analytics coming from the population health management system. There are at least 2 different vendors working together with that customer at their request to actually do this, to get those analytics into the workflow and actually make a difference. This is being done to reduce burden and cost and increase quality. I started thinking about a term that's innovative interoperability for impact. That's what is exactly happening there. So I tip my hat to those folks, and we'll continue to see them innovate and expand. They're actually expanding their panel of members, doing this by a significant percent, like 30 to 40%. They're increasing the use of this on Friday of this week. Let's talk about some other folks in the Midwest, more of on a regional or statewide basis than any singular health system. What these folks are doing is recognizing that there are patients and resources that represent the community. It is a community that includes the caregivers, but it also includes folks that help deal with some of the social determinants of health, like the Transportation Authority, like the Housing Authority. what these innovators have figured out how to do is to bring the community resources into the care ecosystem in a smart and coordinated way. They're actually synchronizing care to improve health among all these various stakeholders. So they're taking sort of the concept of a referral, but adding the ability to do chatting, messaging, tracking, and dynamic follow-up to be able to actually achieve the intended results of getting the people who need care in the community to the people who have the resources to provide that care in the community to operate together irrespective of whatever system they have, and in some cases, they have no system at all. So that creates a new environment that is actually producing pretty exciting results, and I'm hoping to see that this capability starts to take off and spread to other geographies. Again, that's innovative interoperability for a defined and, I would argue, sustainable impact, but we will see. Let's change gears a little bit about a system that I would put in the category of a cognitive system. What makes it cognitive? On the left, you see a representation of medical knowledge. This startup group of innovators have defined ways to essentially have software consume medical knowledge and essentially read it and codify it to make it actionable or programmable. Then they turn their attention to the same thing on payment policy. So if you know what the right things to do according to medical literature are, and you know what the payers will pay for, and you can bring them together in a way that a doctor thinks and acts, you have a chance to really improve quality and get approvals by having the right knowledge in the right sequence, in the right and right defined by the medically accepted best practices aligned with payment policy. In my opinion, this is a pretty significant breakthrough. And the name of this group, by the way, is ACG, or Automated Clinical Guidelines. Big fan of what they're doing because they're applying knowledge in a cognitive workflow. Again, innovative, in this case, information for impact. So I think that that's something that we'll see more of because they're applying the knowledge and cognitive capabilities of machine learning and machine-based coding into ensuring that payment policies are followed so we can perhaps take even more burden out of the system. Now that leads to a large national initiative going on that I have been and continue to be a major fan of what this group is doing. On the left, you see a representation of those same payment policies I talked about on the earlier slide. On the right is a representation of the actual clinical workflows and work done in hospitals and practices. Through the advances in interoperability of the HL7 Fire folks, this is my simplest representation of the work done by the group called Da Vinci, led by Chuck Jaffe and certainly Sagren Moodley, and a lot of great collaborators and innovators on the payers and the providers around the country. What are they actually trying to do? They're trying to get that necessary clinical data for value-based care and create dynamic exchanges between the payer systems and the provider systems by applying the value of HL7 and Fire and using that as a shared language, which you see in the middle. What I think is so wise about what they're doing, the first use case that they're after, one of the early use cases, is just check to see if a prior auth is even required. I think we'd all be surprised by how many prior auth requests are sent without them even being required. So what these folks are doing for their innovative information and interoperability for impact is they're reducing the burden by making these APIs available, so that will lower costs by reducing the work to be done, and it's enabling transparent data, which actually, when done properly, and will eliminate work. So when you think about burden, that's unnecessary work. And if these collaborators continue to exchange data and work on specific use cases, I'm a big fan of what the promise that these kinds of innovation hold for the rest of us. Here's another, I think, great example of a group of collaborators, and this is a vendor and a health system example, or vendors and a health system example. In San Diego, in Southern California, there's a group of really thoughtful and talented executives who stood back and they said, fee for service is clearly not dead, even though, we know that managed care never left California completely. But they still have a lot of work to do, and they were extremely thoughtful about applying the concepts of gamification for the revenue cycle. Not something most people would think about. But what they've actually done is they've said, look, this is the work, these are the tasks, this is what good looks like, and this is what the highest return work looks like. In other words, working your largest claims first and discovering your patterns to be able to organize your workers around the most important things. And the gamification helps them focus their very important labor force, their teams, their workers, on the work that matters the most. And they give them rewards for doing so. So that's where the gamification comes in. So it's a combination of their existing operating environment, plus ensuring that the right work is surfaced to the right people in the right way to get the best revenue cycle results. Extremely important, really helps reduce burden by focusing on exactly the right things. But as you would expect from this group, they're not done yet. What they also have a focus on is there's a lot of repetitive work still that exists in between payers and providers in the world of revenue cycle. With that repetitive work, we see a lot of activity in our industry now about creating digital workforces in the revenue cycle. So they're looking for those patterns and those tasks that are much easier and smarter to put in the hands of machines versus having to have, workforces try to do that and leverage the human mind for the more complex tasks in our complex revenue cycle world. That is taking their revenue cycle productivity to the max by doing two major things. Focus on what matters the most and automate the rest as much as you can. So this is where the combination of gamification plus process automation is really applying innovative intelligence for impact. I'm a huge fan of what these folks have done, and perhaps as we go we can have more sessions with some of these folks so they can expose their great innovations to the rest of the world, to the rest of us. Here's one that sort of touches my heart a little more, and I'll talk about this because I think it has such incredible, deep, and long-lasting societal benefits. On the left is a picture of a doctor and their ability to take their medical knowledge and make it available in a community in a very personalized and very impactful way. The focus here is in a company called BabyScripts. They're in Washington, D.C., but they have customers beginning all over the country. What I thought was particularly innovative and was not just the technology, but it's the information and the content that they have that is personalized to that mother-to-be or mother within the first year to guide them through how to have a healthy pregnancy and then a healthy baby. And they make it very convenient by connecting the doctor's knowledge and experience to them in the greatest and most convenient form factor we know of today, which is their smartphone. So the doctor knows what should happen. They communicate that very well to the mother to be during pregnancy again, and to the young mother with her young child. The objective here is to be able to have children who get off to a really good start. A good start so they can grow up maybe a little bit like this little girl on the right, so they can be happy, healthy, and maybe even just a little crazy. I can say that because that's my granddaughter, and she got good care because of my daughter, and I just think this is something that technology can help us all with. So when you take the concept of great medical knowledge with personalization and mobile convenience, and then you apply that knowledge for that strong engagement with the mother to be or the mom, what a great use of technology to make a lasting impact. It's hard to find or think about another example that would be, more relevant than that one. So I wanted to make sure that we left a lot of time for Q&A or dialogue. So I'm going to be wrapping up here with the following concepts. First and foremost, as we think about it, those of us who've been in this industry a long time, I really appreciate the thoughtfulness and the comprehensiveness that CMS has taken over the years to make continual improvements in focus and to enabling the execution with all the various incentives and programs that they have. So with that as our backdrop, our direction is good, and it's clear as an industry despite the fragmentation and the dynamics. So each of us has a responsibility to sort of take a step back and climb up on the top of a hill and sort of look at the landscape and say, my destination is based on where I am. My destination is based on what I see, where I should go, and what am I going to do about it. So that there's a lot of complex things to think through here, but again, clear direction, clear problems to solve. No one thing or one body or one person can do it. So I ask us to think about the collaboration that is needed for all of us as we innovate to solve these problems. I'll sort of close my official talking with something that came from the CAQH index that was published just last week. I thought they said it very well, and it reads like this. As value-based payment arrangements continue to grow, understanding the role of administrative simplification in the clinical workflow could help to align administrative and clinical activities among providers, payers, and consumers. So, if we're looking to make an impact, and that was the end of the quote, if we're looking really as an industry to make an impact with innovation, let's clarify our visions and let's focus on areas that we can actually make a difference and measure the results and do it smartly and carefully together. With that stated, I'm going to kind of end the formal part. I want to once again close with thanking Weedy for giving me an opportunity and, asked to share my thoughts on where we're all going and share some of my vision for 2020. But it's all about how we all work together more than it ever has been before. So I'll end, Samantha, with a big thank you to you and Charles, and open it up for any questions that might have come in.
Thanks so much, John. While other folks are typing in their questions, I think especially I'm a millennial and I can't even remember the last time I used a fax machine. How do we move healthcare out of the fax machine age and towards, what are the baby steps that Weedy can help the industry take?
That's a great question. I think that the same level of rigor and thoughtfulness that was applied to getting electronic claims now needs to be focused on attachments and prior authorizations because that's medical knowledge. To tell you a sad but true story of last week, my mother had a radiological procedure done just before Christmas, and they lost the radiological report, or it was stuck somewhere. And they told me that their fax server hadn't completed sending it to the providers. I actually had to intervene, get them to send me the fax, send it to the providers, and she lost 60 days of treatment as a result of this. So this is really personal, okay? So I think the more that Weedy can do what Weedy has done with the PAGs and convening the right groups, I think Seema Verma actually said something about this not long ago. Let's take up the cause to get rid of fax machines. Just get rid of them. They're not necessary, but they're sort of a crutch and an inconvenient convenience.
Thank you very much, John. Another question that's come in, how far off are we with the ON site from
Samantha,
smartphones playing a much larger role in health IT?
I'm sorry you cut out there. Is it Owen? How far away are we?
Sorry, how far off are we with the ONC proposed rules in sight from smartphones playing a much larger role in health IT, and what is their potential?
Wow, a great question. I don't think we're far off at all. Huge kudos to Dr. Don Rucker for leading the way of really sort of demanding an API economy in healthcare. So the way that cell phone applications work, it's through a series of service calls, and that is essentially the model that I believe that ONC has put forth. I know that because I've heard him speak about it, and I think he's absolutely right. The So I don't see any quote unquote barriers from ONC at all. I see quite the opposite. I see accelerators. So as soon as we can get the information blocking rules out, and as well as the continued innovation and stimulation that the government is trying, as well as the use cases, like for example, the baby scripts one actually works that way. It uses its smartphones as the delivery vehicle out to the consumer. I think we're not far away at all. I think all the right controls and motivations are there. Now it's up to the collaborative innovators to come together and build out these use cases. It's wonderful that we have the smartphone infrastructure to use, and as all the providers and the payers want to see patient engagement and member engagement, there is no better platform than smartphones to be able to facilitate that part. So I don't think we're far away from at all. I think some of it's happening now. It's at scale and mass with collaborators, plural, pulling it together.
Great, thanks, John. Another question has come in. How do we balance the need for these newer technologies with the fact that there are hundreds of rural hospitals and organizations that run on stringent budgets and who do not have the resources to utilize these technologies?
I think that's another really good question. I would also, if I could, if you don't mind me kind of modifying it and roping in the community health centers and the FQHCs, right? Those folks have similar economic challenges. I think there's two things. First of all, the ubiquity of connectivity has continued to grow, and some of the big wireless carriers are, committed and active to try and bring it out further. So you need infrastructure to do this, and I think there have been a lot of grants to be able to facilitate the innovations. I'm not smart enough, or I don't know, let's say I'm not smart enough to think through what kind of payment policy would be good, but we do know that these institutions have some level of subsidization. What if we created a standard IT enabling package for all this value and use that as part of the subsidization? I don't know if that gets in the way of legal and charters and things like that, but instead of just subsidizing with dollars, what if we also subsidized with working solutions? Maybe that's something, that would be worth pursuing. But it's a very important problem that some of the large health systems have both folks in community, in settings like that, as well as in more populated communities. Great idea to think through that and act.
Thanks, John. And feel free, if anybody else, make sure you type in your questions. What is the relationship between interoperability rule, transparency rules for hospitals and plans, and the surprise balanced billing proposals all come together, if at all?
That is a huge question for I would say a panel of experts. But let me try and break it down. Transparency of data means it is available in my mind. So you can't hide it, you can't hoard it. It has to be made available. So I'd say that's step one. Interoperability means that the data, when it exists, has a different place to go other than the system in which it was originally created. So that's how I'd say transparency meets interoperability. Surprise billing would be, I think, is more procedural. It probably requires those two things, but you should be able to make the data about the cost of the treatment available for visualization, for being able to see it in some system or another. So I'd say data creation and transparency, make it available. Interoperability, let it move. And the third one is a specific use case of the first two together. And I should probably say, these are not, weedy comments. These are, John Zimmerman, who's been in this industry a long time, comments. So I don't want to get anybody in trouble.
Of course, and we appreciate all of that experience being shared here on this webinar. Another question that's come in, do we expect ONC or CMS to come up with any interoperability rules to accelerate the HL7 FHIR adoption through Da Vinci or DRLS?
I would argue that the rules are sort of out there. ONC and CMS are very supportive actively with Da Vinci, but I don't think they mandate the specific uses of technology per se that Da Vinci actually is. They create an environment that says the things that they're saying. Data has to be free to move, and here's your incentives for being able to deliver better accessibility, better affordability, and better quality. You, industry, can go get together now and work through it. Now, I think they're going to continue to give the industry time to figure it out. But the day may come that they say, enough's enough, we're going to make the rules. I don't see that in the short term because of the progress being made with the innovators in and around Da Vinci and other areas. It's possible, but I think they're smart they're pretty darn smart the way they're going about it right now.
What are some small steps that the industry can take to improve the prior authorization process? Is it going to take government intervention?
Well, it's clear. Well, two things. It's clearly a focus of all the parties. It is a function of all the various stakeholders in the industry. It is a function, one of the factors in physician burnout. If you read the CAQH index that came out, that is the one that is the transaction set. So it is clearly noted. I think the building blocks of a solution are already in place. If I had a magic wand, I would ask maybe somebody like CMMI to start some experiments around the country with trusted parties and different ways to go do this. Prior authorization is a very complex task, right? Or a complex set of rules that needs to be done fundamentally, best case, instantaneously at the point of order, because that's the point of order. Making an order is a clinical function. Prior authorization is an administrative function. The administrative functions typically work in data exchange, but not directly with this complex medical information required to determine appropriateness of care. So we're actually, some of my friends from ACG, we're talking to a health plan next week about maybe there are some new ways. So if we want to do this nationally, again, there's good innovations going on. Some of those small steps, I would say, would be multi-stakeholder collaboratives with some very targeted areas. Maybe you pick on orthopedics or cardiology. Those are some of the things that I would figure out how to go do with stakeholders who can spread it right after. So, sort of answering your question in the term that it was posed. I don't know that there's any small steps, but I think getting the right collaborators together and doing sort of disease area or condition area experimentation and coming up with new ways in order to address it, I think would be a really good start.
So who do you think those right collaborators are?
Payers, providers, both government and commercial together. And I would say both hospital and practice and a few selected vendors. And when I say vendors, I don't necessarily mean the big giant vendors. I'd say there may be some startups. So I think that's a great question to maybe bring to the Weedy board and to think through how do we go do this, right? But they have to do it all locally, right? I think that's a very important point. Healthcare with national standards does work similarly across geographies, but every community has their own combination of players. So those are the collaborators that I would see.
Thanks, John. Another question. It is getting increasingly complex to define value-based care. What do you suggest to define in a couple of sentences to people?
That's a great question. Let's see. I think it's at the essence where value-based care happens when a population is getting the appropriate care for all of their conditions in all of the right settings. Now, that's a broad brush, but if you think about it, right, value-based care is primarily driven at chronic disease management. And the best way to take care of chronic diseases is to do all of the appropriate protocols and stay ahead of the onset and growth of that chronic disease. The emergency room is not a place for dealing with chronic diseases. That's where you know you have failed. So I would step back and think about, value is had when it's affordable, it's accessible, and it's appropriate. So that's why I would start with that. It's a great question. I'll probably go work on that in my spare time to be able to come up with something pithy, but all the right care for the right people in the right settings at the right time actually gives the outcomes, provides the outcomes for value-based care's intentions.
Thank you very much,
But
John.
with
Oh, go
with
ahead.
our fragmented system, it's really hard to do, to your point.
Yeah, yes, very hard. That's all the questions that have rolled in at this time. Do you have any last thoughts or parting wishes that you would like to share? Oh, wait, hold on. We got another question.
Ah,
How do we make
okay.
sure you can be thinking about your parting thoughts after you answer this question? How do we make
Okay.
sure
Thank you.
with all the innovation that is occurring that we are able to encourage patients to play a larger role in coordinating their care through the use of technology without leaving behind and allowing the less technologically savvy population from holding the healthcare industry back?
I can see why that's the last question because that's extraordinarily thoughtful. Not that the others weren't. Let's see. Um, First of all, I think it's an important thing to correlate how you feel and and what you do. In other words, if you like to go outside, if you like to play guitar, if you like to ride a bike, if you like to be with your friends, you can't do that when you're ill, right? It just takes away all of your um, life desires. So the idea would be to be able to A, correlate what that individual wants to do with their own lives, irrespective of health, and then talk about how they can use their communications device or their life device that they usually use, which is a smartphone in so many cases, and say, did you know that I can help you do that? I mean, there's one just awesome example in the world now, I would argue, which is Livongo. What Glenn Tolman and the crew basically invented that level of personalized and convenient diabetes management. I think that's a marvelous step in the right direction to address what you're saying. The other thing is to work with people like me, and not as a technology guy, but I am the son of a mother who is in her she'd kill me if I said how old she was, but she's not young. And I am her patient engagement portal, right? I get on her portal for her, I find things for her, and I am her coach. There's a bunch of us in the world who do that. So, the family and the caregivers within the family or the care coaches within the family play an important role. So if you can't get to those without technology, and I know that doesn't cover everyone, but where they do have access to somebody who does and that they trust, that's probably another good example.
Well, thank you very much, John, for your time today and all of the effort and energy work you did on the PowerPoint presentation and putting this together and sharing this with us. This is fantastic. Really appreciate it. And do you have any parting words of encouragement for us as we head into this 2020 year?
Uh, my parting comments are, Samantha, again, back to you and Charles. Thanks for inviting me to have this dialogue. Team on the phone, thank you for your questions. Anybody could talk for a long time. It's the dialogue and the collaboration that matters. I love the theme of setting your vision. So my encouragement to you is two things. First, um, think outside yourselves, outside your immediate, product or capabilities or business, be it a payer or provider or whatever. Think about that ecosystem and the other folks that are touched by what you're trying to do. So go up on that hill and look around and see what's around you. It'll help you define what matters, who else is there to collaborate with. That's one of the ways that Weedy was born. And I'll end with a quote from a great song from the 80s as a duet where, two is more than one, and it was great, by Kate Bush and Peter Gabriel. Don't give up, right? There's a lot of great things to do. Let's stay focused on them and keep making progress. So thank you again, Samantha, for having me today and for the audience.
Thank you so much, John, for being with us today, and thank you for all of our fantastic attendees for your participation. I'll be following up with a few emails with the slide deck and also the link to the recorded webinar. Feel free to share with your colleagues. Thank you again. I hope everybody enjoys the rest of their week.
Take care, everybody.